Welcome to the BeeHive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
So good morning, we're here on Be Kind Pediatrics. We're going to be talking a little bit today about RSV and bronchiolitis since it is RSV season and it happens to be making a big appearance in the news. We wanted to give our families and patients some information to empower them to take care of their children at home. So what is RSV? RSV is a virus that causes bronchiolitis. It's one of many. Influenza, human metapneumoviruses are just a few others that also cause the same disease. And that's why children can get bronchiolitis more than once a year. Often they do get it more than once a year, and certainly more than once in a lifetime. It is very, very rarely caused by bacteria, and so that is why we almost never treat it with antibiotics. If you think of bronchiolitis as an infection, it's an infection of the very smallest airways of your lungs. So if your lungs were a tree, your nose and mouth would be the trunk, and your bronchioles would be the very lower root system of that tree. And as bronchiolitis starts, it starts actually at the top of that tree in your nose. That's why it usually starts with congestion and runny nose and spreads down into the lower airways. That spread usually takes 3 to 5 days, which is why we start to see signs of respiratory distress as the infection spreads into the lower airways on day 3 to 5, which also happens to correspond with the peak of illness when this illness typically is at its worst. So why do we only see this in children? That's actually not true. Adults get bronchiolitis just like kids, but small children have very small airways. Your lungs actually take about 25 years to reach their full size. So if you think of your bronchioles, those very small root systems, as straws, an adult bronchiole would be like a normal straw, and a child's small bronchiole would be like a sipping straw. So if you tried to pull air through a swollen normal straw, you would probably be okay. But if you pulled air through a very small sipping straw that was then swollen, it would be very hard to get that air through, and that's what it's like for a child to breathe with bronchiolitis. Now, if you add on inflammation to the airways, if you add on mucus production, which is the second part of this disease, and as mucus gets dried up, it actually becomes more like a cement. So if you put a little cement block in that tiny straw or a piece of grain of sand or something and tried to pull it through, you could imagine again how hard that would be. And that's again what a small child is kind of experiencing with bronchiolitis. So the heart of the problem with bronchiolitis for small kids is really airway swelling and airway plugging with thick concrete cement. And children who are particularly affected by this are small children, usually less than 6 months of age, but we can see it up to 2 years. And children with really bad or severe risk factors like those less than 12 weeks, premature babies, anybody with cardiopulmonary disease, immunodeficiency, and then also those with tobacco exposure, because tobacco exposure hurts the little hairs that help us move that cemented mucus out of our lungs. So what's going on in the news? Currently, we're seeing a peak in RSV unseasonally. Usually it peaks in February, and it's been peaking every year since as long as people have been taking care of children. And usually hospitals and ERs and ICUs actually prepare for RSV season. Sometimes they even make their staffing models around this. So an unseasonal peak can catch us off guard. On top of that, across the country, we've been seeing closures in pediatric inpatient bed and units. So we have less beds, and we're not really typically seeing a peak this early in the year. We don't know. It's too early to tell if this is the cases are going to continue to go up or if this is just going to be an early peak. There's no way to know this early on. But with the fact that we have less inpatient pediatric beds and we're seeing an unseasonal peak, it's even more important for parents to be able to take care of some of this illness at home. And so we have Dr. Gowdy from Atlanta here. He is a pediatric ear-nose-and-throat doctor. He's also the creator of my favorite at-home suctioning tool, which is the NozeBot. My son had RSV this year. We treated him with saline and the NozeBot, and we got through it, I'm glad to say, without making a trip to the ER. So welcome to the show.
Thank you. Thank you.
I'd like to ask you a few questions, if that's okay, about upper respiratory tract hygiene as you've kind of coined the term, I think.
Right. Happy to talk about it.
So what is RSV hygiene exactly?
I mean, RSV, as you already laid out and was very eloquent about, it's a virus, right? It's not a bacteria. It is something normal. It is one of many viruses, the flu, rhinovirus, enterovirus. So it is a virus. It has a significant impact, but all of these viruses cause nasal congestion and mucus production, or the cement. So you can coin that term, cement. I like that. But really thinking about how the hygiene, right? We all kind of want things to be clean and work well. And the nose is one of those very important things, particularly for young babies. So young babies are obligate nasal breathers, meaning that, the way that their body is set up, that they have to breathe primarily through their nose so they can eat and breathe simultaneously, right? But if they get a lot of congestion or a lot of mucus or a lot of cement that's built up in their nose, they don't breathe well, they don't eat well, they don't sleep well, they get dehydrated, they become lethargic. So it's like this vortex of illness. And as an adult, you feel the same way. You're like, gosh, I feel terrible. I don't want to eat. I don't want to drink. But for kids, their metabolic rate is so high because they're growing, right? As adults, we're just sitting around on the couch eating potato chips. But these little creatures are just like dividing and growing a lot. So their energy needs are a lot, but they don't have, huge stores of energy. So, anything that blocks up or reduces their ability to breathe has an outsourced impact on their energy stores, on their ability to grow, and just they get tuckered out. I mean, that's plain and simple. And you work in the ER, so you see it. I mean, they just get plumb worn out, and parents don't really know that, or they can't sense, and they don't, like kids are running around. The gas gauge is always on a quarter of a tank, whereas you and I may be at a full tank. They're on a quarter every day, right? And then all of a sudden, if they get down to the light going off, that's when you really have to get worried. So nasal hygiene, as you mentioned, saline, plenty of fluids, and just suctioning out the nose is hugely important, because then your child can fill up their tank. They can get off of the red light and sleep well, and then you sleep well too. So there's a couple added bonuses.
Right. So that's why I've kind of always told parents, both in the ER and outpatient, what you really want to do is keep that mucus really thin by keeping it hydrated. So the way that we can to keep mucus hydrated is with the nasal drops. But then it's important to actually get that mucus out, which is why I think your NozeBot is so great, because it's hospital grade suction. Can you talk a little bit more to families about why hospital grade suction makes such a difference compared to, for example, bulb suction?
Obviously, I'm biased. I love the product we've created because it was created based on, me being a pediatric ENT and having 3 kids and knowing what the pain points of parents are. But, you're sent home with a very complicated thing after maybe a day in the hospital, given this blue bulb that you can put in their nose and clean out their, as you mentioned, Blair, the people have been having viruses for as long as like humanity's existed. So people have been dealing with this a bunch of different ways. There's the term called the mother's kiss, which, not to be gross, but people would literally suck the kid's boogers straight out of the child's nose with their mouth, right? But before the blue bulb, that's legit what had to happen. As you might imagine, that viral transmission to you is going to be 100%. The blue bulb also works, but it kind of goes deep into the nose, and it really kind of creates this vacuum to work. There's a bunch of other stuff, but the reason why we created the NozeBot is because it allows you to stabilize the face and suction simultaneously, and you're not using your own mouth, and you're not like pushing things inside the nose that can irritate and cause trauma, because when these little kids get sick, they're just booger factories. I mean, they have boogers everywhere, and you're going to be doing it a lot. So doing it in an atraumatic way that allows them to breathe, but also makes it efficient for you, I think is an advantage, and quite honestly, I mean, I don't know that every child that gets RSV can be kept out of the ER like your child, but I mean, it's another tool in the toolbox for you to kind of get on with your day, help your child breathe, because there's nothing more precious than your child, and there's not a more vulnerable feeling than watching your child not be able to breathe and eat. So I think it's what I want people to take away is like nasal hygiene is very important, not only because your child can breathe and eat, but it also reduces the likelihood of infections. as you said, that if that concrete sets up, right, it's hard to get it out. And then it can block up your sinuses, it can block up your ears and get, so the likelihood of having a bacterial infection after a viral infection is about 10%. There's some reasonably done studies that show that saline reduces the likelihood just because, as you said, Blair, you're getting rid of the concrete, so things are flowing more smoothly. And there's some European studies that suggest that powered nasal suction helps reduce infections as well. So, and you feel like you're helping your child breathe, which is incredibly powerful.
Right, yeah. Sometimes, and I've had this experience before where we admit a child to the hospital and all we're doing is nasal suctioning, and it's very frustrating for parents because they feel like they can be doing it at home, but
Yeah,
sometimes I think that hospital grade suctioning, and in the case of a hospital where you sometimes do have to keep children deep suctioning, which you cannot do at home,
right.
does really make a difference for kids. And I always like to tell parents, another reason why I love the NozeBot is because oversuction can also cause too much swelling if you don't have the right
True.
tool. So something that can actually go into your child's nares, where the NozeBot stops you from being able to do that. Doing that too often can cause edema and swelling just in and of itself. So before the NozeBot, I actually told parents, try to preferentially suction your child before and after they're going to sleep and before you're going to feed them because of the reason you just said, right? Because kids can only really breathe through their nose. So if they can't breathe through their nose, they're not going to put something in their mouth to eat. They're going to choose breathing over eating, which is just going to dehydrate them and make that mucus more cement-like.
Right. Well, and I think so. Two things. One, the nose, like the moment I knew that we needed to have a better solution for families is when a parent looked at me. I was in their room. Their child has Down syndrome, which, those patients really suffer with nasal congestion at baseline. And she looks at me and she's like, "Doctor, I don't need you. I just need this suction on the wall. I want to go home. I need something better that works." And I'm like, okay, well, there has to be a better way. And so really that origin story is why our company is also focused on advocacy for the Down syndrome community, and that's part of where our profits go, is to support that community. And then secondly, I think as you kind of alluded to, if a child has to decide, do I want to breathe or do I want to eat, they're going to breathe. But by breathing out of their mouth, they're really not, the function of the nose is to trap, pollen and viruses and so on, so it doesn't go to your lower airway. Number one, and number two, it warms and humidifies the air. So if your child, if you're sitting around and child and go, it sounds like Darth Vader, they're not warming, they're not humidifying the air, and it gets down into their lungs. It makes the concrete worse, and so you get concrete on top of concrete on top of concrete. And people are like, well, why is my kid coughing so much? It's like to your point, like they're trying to get the concrete out because they want to breathe, and so that humidification is hugely important because that's what your body does. That's what your nose is for. There's all these videos on TikTok about, the merits of like nose breathing and so on and so forth. And it's a filter. It's a humidifier. So, I don't know if you want to kind of even go down that rabbit hole, but the humidification part, the saline is not just cleaning out the nose. It's also allowing your child to humidify their lower airway.
Yeah, I love that you said that because, again, the ER part of me, when I would see children in the ER, and the first thing I would really worry about is dehydration, especially with patients who are tachypnic. My younger doctors or student doctors would always ask why, because unlike an adult, children breathe very fast at baseline. And so they need to have twice as much humidification power for the twice as many breaths as they are taking. And so when they become tachypnic, they are losing a lot of fluid breathing that fast and trying to humidify that air. And so sometimes I've even seen the case where we just give a child a little bit of IV fluid and they look so much better and they can go home and try to hopefully stay hydrated at home. But hydration is also such a key part of this treatment, and it doesn't make sense easily to a parent. I think when you're saying your kid's having breathing problems but they need to drink more fluids, they're like, how are the lungs and fluids related? And that's exactly how they're related, I think. And I love that you were just talking about upper airway, how it acts as a kind of barrier for viruses and diseases. So I mean, I think I'd love for parents to know a little bit about should they be suctioning and doing respiratory hygiene even when their child's not sick? How can that potentially help their kid if they should be doing it?
Quite honestly, I think that's very individualistic. I mean, a lot, and I want to dispel one myth. There's a lot of people that assume that small babies that have runny noses have allergies, right? So, kids get sick all the time, particularly in their childcare, 6 to 10 times a year, maybe more. And so if your kid has a runny nose, it's probably not allergies, it's probably a cold, right? So if your kid is sick all the time, you need to have good nasal hygiene and wash out the nose with saline or, something. You don't want to make that stuff at home, right? You don't want to like introduce things that isn't sterile and clean into your baby's nose. If your child's older, then I think maybe, and they're prone to allergies. I think nasal saline, other ways of getting rid of the pollen and all that stuff makes sense. But if your kid's healthy and fine, I don't see you chasing around the house to like make them do that necessarily. As they get older, I think if you have concerns about allergies and so on, there may be some other adjunctive therapies you can use to manage it. But, if your kid's fine, just enjoy your kid being fine, for the 2 or 3 days that's going to last. And then when they get sick again, which again is completely normal, I think then use the nasal hygiene and so on and so forth. And as a parent, like a couple of my kids went to daycare and I did the daycare shuffle. I mean, sometimes it's hard to know, like, why is there something wrong with my kid? Like he's always sick or she's always sick. On the physician side, I want to know, are they having ear infections all the time? Are they having recurrent pneumonias? Are they having weird skin infections? Those are the kind of things, the subtle signs that we look for to say, okay, your child's immune system may be different. Versus if your kid is in daycare and literally is like slobbering all over the same thing that 10 other kids are slobbering on, they're going to get sick. And I don't, that at least that's my perspective when people come in and really want to talk about those kinds of things about the frequency of illness and so on.
Yeah, again, that's why I tried to start off when we're telling parents about bronchiolitis that it's not just caused by RSV. There's actually hundreds of viruses out there that cause bronchiolitis, and your child is going to systematically get all of them, whether they're in daycare or not. It's just a matter of time about when they're going to get them. And so you can expect that, an average, a normal child is going to get bronchiolitis or at least an upper respiratory tract infection about 9 times a year, is what we say. So, twice a month during the winter season at least.
Yes.
And then my one last question for you was really about the technique of suctioning. So I've seen a lot of different variations of this throughout my training, and as a physician myself, I've seen nurses and physicians and parents, everybody, pediatric care providers, put the saline in, immediately suction it out. I've seen some wait, 30 seconds, some wait a minute. There's all different, variability in there. And I was wondering, does it matter, the steps in which you do it, how long you wait, any of that?
It depends, right? Like if it's 2 a.m. and you're trying to like do it really quickly and get your kid back to sleep, then I think you just do whatever you got to do. But to use the analogy that you used earlier, like if the concrete is really set up in there, you're going to have to chip away at it. You may actually do several cycles of saline and then suction and then saline and then suction. I personally, I mean, the saline, again, buy sterile saline. Don't like if you're going to make it at home, you need to read the instructions and make sure you're boiling the water, doing all this stuff, because you don't want to add a different problem to the problem that's already going on.
I've always kind of felt, although I don't know if there's any actual science to back this, that waiting a couple minutes makes the mucus come out easier and more of it.
Yeah, but it's hard to do because your kid's already like crying and mad.
You're already
and
holding them
and,
down.
Right. It already seems like it's a battle royale. So I mean, not going immediately to suction is probably the best thing. But if you have to, then you may just anticipate like, hey, I'm gonna like put it in suction, let my child eat for a little bit, burp him or her, suction a little bit more, and then kind of loosen it up a little bit.
Great. I mean, those are all the questions I have for today. I don't know if you have any last minute tips or tricks for parents, but it seems like you gave us a whole lot of useful information here. And I'm really grateful for you coming on the show today.
Yeah, I mean, I think the parting thoughts is number one, it's hard. Nobody tells you how hard it is, particularly when your kid's sick and how vulnerable you're going to feel. So you need to acknowledge that and and be okay with that. And having a really good relationship with your pediatric care provider is important because figuring out when to be worried, right? I mean, we go into healthcare and particularly pediatrics because we deeply care about children. And so reach out to us. And so, if your kid has nasal flaring, that's not normal. If your kid is lethargic, that's not normal. If they're retracting with the skin above their neck or under their chest or whatever, like if you see weird stuff, you need to let us know.
Yeah, we are going to do some closing topics. I'm glad you brought that up about when you should see your doctor. And I always preface this by saying you should see your doctor whenever you're concerned, because parents really do know when something is not normal for their child. You look at them all day, every day. I look at them for 15 or 20 minutes during an exam. There's a big difference in my knowledge of your child and your personal knowledge of your child. So if you think something is not right, absolutely, please call your pediatrician. And every pediatrician didn't go into pediatrics to become rich. So I'm hopeful they wanted to hear from you if you're concerned. Um, great. Just like you said, signs of respiratory distress are going to be breathing quickly. Then you can see that your child might start to use extra muscles to breathe. Those are going to be the spaces in between their ribs going in and out. You might see them pulling here, so the spaces between above their clavicles coming in and out. Nose flaring. And some children will grunt when they're in severe distress. They'll make a grunting sound. That's them trying to pop open their airways. If you hear that sound, you want to call your doctor right away. That's a sign of severe distress. And like you were saying, all kids are running on half empty. So if they're breathing fast and they're using extra muscle to breathe, they're eventually going to get tired. And that's where the ER doctors and the critical care doctors start to get really worried when a child starts to become tired from breathing. So that would certainly be another reason to call your doctor urgently. Dehydration, like we were talking about, if your child can't breathe, they're not going to drink. So they might not be making wet diapers. They might not be making the same amount of white diapers, but they could also be making not the same quality, so less heavy wet diapers. You might see that they're crying without tears. That can be another sign of dehydration. But really, parents are really good at picking up on when their kids are not drinking the same amount as they are. So if you start to notice that, please call your doctor. And then fever. We always say persistent fever for what you were kind of talking about earlier on in the show. When fluid gets built up in your nasal passages, it gets built up behind your middle ear, and that fluid is sitting there waiting to get infected by bacteria. So it's not uncommon with RSV and bronchiolitis for children to get a bacterial infection in their ears afterwards. So if your kid was having 99.7, all of a sudden they're 102 for 2 days, please, reach out to us. We want them to come in and we want to check their ears.
Yeah, but kids are also resilient. Like I was in clinic yesterday. I saw a child who almost, did not survive RSV and had all kinds of consequences and infections. And now he's like, I'm great. What's the problem? So kids bounce back so fast. It's they can run out of gas in a hurry and it gets super serious, and you bring all of the resources to bear, but then but also know that they can rebound quickly, whereas if it was me, I would be still laid up in a hospital bed for the next 6 months. So yeah,
they are truly amazing in that capacity. But
yeah.
I just wanted to take the time to thank you one more time for coming on the show, and thank you for creating that device. I really do feel very strongly about it, obviously, but I feel like because of that case we were talking about earlier, it's so nice to be able to tell parents when they're in the ER in the hospital and they see you suctioning them, they're like, I just need to bring this home. And you're like, well, there's something you could bring home. It's just a really nice resource to have for our families out there. So I appreciate your time, and I appreciate you coming on the show today.
Yeah, absolutely.
Thank you for watching the BeeHive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com, and don't forget to subscribe for more parenting tips wherever you get your podcasts.